Rightio. This is just an online version of a presentation about the Consultation Liaison Psychiatry Service at an upcoming eating disorder forum. The first part of the thing is fairly straightforward. It's about who. We're a small team. We have a psychiatrist, Shamila. We get 2 new psychiatric registrars every 6 months. At the moment, we've got Manju and Owen, and there's 2 CNCs on the team, Yelena and myself, Paul McNamara. Most of this presentation is about the what and how of Consultation Liaison Psychiatry Service when it comes to helping out with people who are experiencing eating disorders. Well, at the risk of being a smartass, we do 2 things. We do consultation and we do liaison. Let me show you what that looks like. This is a file entry in IMR, the electronic records that we use, and it documents a consultation that we do. And part of the really important part of the consultation is that we try to understand who the person is and what's going on for them. And we try to, as part of that, understand what their goals are of the admission and what distractions are going to help, or what factors are going to help them get there and what factors are going to hinder them to get along. And this is really important, that we not only collect this information but that we share it with other members of the clinical team. We are part of a big machine really when it comes to the recovery for somebody experiencing relapse of eating disorders, and we have this privileged position where we get to sit down and have long conversations with people. It's not unusual for the people that we're trying to support is that intellectually they understand the reason for the need for nutritional restoration, but actually putting that plan into place is a bit tricky. Not unlike, I guess, smokers. Most smokers know that cigarettes aren't good for you, but giving up's a different thing. Same sort of mindset sometimes. So that's the consultation. Then the other really important part of what we do is liaise with other members of the nursing and medical team and the dietitian. And we need to put together a plan and communicate that plan for the whole team, not just between us and the person. We recognise that we're a small cog in a big machine. In red here are the inpatient components of care: Consultation Liaison Psychiatry Service, the dietitian and the medical and nursing teams. And we all have a role to play during the inpatient component, but we're only a small part of the story collectively. For the person themselves, I'm sure that they value their family and loved ones more than they value us. And we're also aware that they spend more time outside of hospital than in, and out in the community. There are teams like the North Queensland Eating Disorder Service, GPs, psychologists and psychiatrists, and sometimes mental health nurses in private practice. There's the community mental health, the public community mental health service, and there are other community supports out there too, dietitians and various other people who will all add to the care of the person who experiences relapses with their eating disorder. Our job is to communicate as best we can with all of those teams. One of the things that we communicate for the inpatient team as best we can is try to separate the person from the eating disorder. And this is really important because sometimes the eating disorder will try to sabotage the recovery. It's usually not the person, it's the eating disorder that's driving those antisocial sabotaging behaviours. And it's really important that we don't get caught up on blaming the person. We don't want to lose empathy for the person that we're caring for. That would be a disaster. One of my favourite examples of separating the person from the eating disorder comes from a mother and daughter who thought of it way before than I spoke to them, and they'd already named their eating disorder Regina. And I was like, why are you calling the eating disorder Regina? And they said, in the movie Mean Girls, Regina was the meanest of the mean girls. And it's just a lovely illustration of how it's important to separate that bullying eating disorder and the bullying behaviours of an eating disorder from people who are usually very sensible and likeable people underneath it all. It's when they get malnourished, when the eating disorder takes over, that it gets pretty tricky for everyone. An important part of our role is to support the nursing team with their everyday nursing activities. We don't need to invent this. It's all been catered for for us. The Queensland Eating Disorder Service has these terrific guidelines which are available online on the Queensland Health website. But the Queensland Health website's a long way away from the patient sometimes, so we take the nursing instructions there and pull them into IMR, the file entry that people are working off, and put those instructions there so they're more easily accessed. Probably more importantly, again, we take those instructions and we put them in the orders section of IMR. Those orders are the bits that the nursing team usually work off to help them organise their tasks for the day. Everything from, not necessarily for eating disorder patients, of course, but, if there's IV medications and blah, blah, blah. And the big things that we look out for there, want a daily ECG, we want a weight every Monday and Thursday, we want monitoring of blood glucose levels, and we certainly want monitoring of postural hypotension, and probably more pertinent for most people with eating disorders is postural tachycardia. And if we've got those orders in IMR, it just makes it easier for the nursing team to get those jobs done. Another thing is that sometimes for people with eating disorders, we recruit the support of an assistant in nursing. Now, assistant in nursing has done a TAFE Cert 3 or 4, I think it is. And so an assistant in nursing, or AIN, can be delegate tasks, but we can't delegate responsibility to them. They're not registered by APRA, and they haven't. The rest of us are running around with degree level education, and they haven't got that. So it's important that we spell out for the AIN, if we are asking them to be involved, give them an understanding of why the patient's here and why they're here, and give them pretty clear instructions about what we want them to do. And some of the things that we ask AINs to do is pretty full on. If you've got an eating disorder, when a meal turns up, it can be a really anxiety-provoking time. And so to distract people from that anxiety and to model and promote mindful calmness so they can complete the meals to the best of their ability is a pretty tricky task, and it's not too much of an ask for the senior members of the nursing team to provide some tips and instructions on how to achieve that. And that's the idea behind these info sheets for AINs. We individualise the info sheets with the AINs. We individualise them to each patient. We discuss the plans with the patient. It's about them, it's for them, so it's not done behind their back. And they get a copy too, so they can all stay on the same page. And we review the plan regularly. And we invite suggestions for changes from either the AIN or the patients. If they've got ideas on how to improve how we're doing business, let us know. And if we think that's worth a try, we'll give it a try. So that's all the documentation side of things. A bit more esoteric is the bit where we get involved in helping people manage the transference and counter-transference. So just as a reminder, transference is thought to be described as the thoughts and feelings that the patient brings to the patient-clinician relationship. Counter-transference is the clinician's thoughts and feelings that they come along. So sometimes if somebody's really struggling with recovery from eating disorder, their transference might be pretty hostile. They might be really angry at us for imposing restrictions on nutrition on them. And it's really important if the person is being hostile that we don't just fire back with our own counter-transference and get equally hostile back. We need to be smarter and stronger and wiser than the eating disorder. We need to acknowledge that there will be ruptures and repairs in the relationship between the various members of the clinical team and the person receiving our care at times, but we try to minimise those ruptures and speed along those repairs as best we can. We need to also acknowledge that there may be ruptures and repairs between the various components of the clinical team, because there's a lot of us there. It would be weird if occasionally we didn't have different opinions about how things should best be managed, and we need to be speaking to each other because it's not really about our ego, it's about what's going to be best for this person at this time. And as long as our communication stays open, usually we'll come up with a pretty good solution. So that's the potted version of what we're talking about at the conference. I hope this video version has been of assistance. Thanks for watching. Cheers.